here again, and thank you so much for the kind invitation. So I have nothing to disclose as a conflict of interest. And I do talk a lot, so that's the reason I like to put the slide first so I can just catch up with it before the time ends up. So when we talk about the failed pouch, I think we need to define exactly what we're calling as a failing pouch. Is it a mechanical issue related to surgery? Is it a really idiopathic pouchitis, or is it both? Or is it Crohn's disease? And it's important trying to differentiate the differences between the three. It's all about history, history, history. When did the complications started to happen? If somebody developed their complications immediately after the ileostomy closure, after pouch, that's most of the time mechanical. If somebody had 2-3 years, more than a year, no problems, then they start to get issues, that's likely a Crohn's disease. What's important, what the patient wants, it's important this is a multidisciplinary group of collaborative work, and the workup is needed. Revision and the reconstructions options are all on the table for these patients, complemented by the liberal medical care therapy, even if there is some concerns of Crohn's disease is high. And this is the infrastructure that the institution needs to understand. They need to provide the caregivers so they can deliver the care to the patients. Let's talk about the pouchitis. Patients ask me whether they're going to get a pouchitis. I told them it's like asking me whether I'm going to get a flu. So the longer the fact that somebody is going to live, they're going to have one episode of pouchitis in their lifetime. So it's pretty high. But the fact is the chronic pouchitis rate, which is a continuous symptoms like this greater than 4 weeks, is actually pretty low, around 1 to 4%. It's a wide spectrum of disease. It can be antibiotic responsive, dependent, chronic antibiotic refractory pouchitis, and all the other three that can be seen in the slide. The pouchitis symptoms also can vary, but most of the time it's like a diarrhea, like a flu type of a symptoms. One thing that separates, in my opinion, the pouchitis than the surgical complication, if they have a coccygeal pain, that's a more sign of a septic complication. The risk factors itself, to me, the number one risk factors that I'm going to come, honest to God, it's the surgery goes wrong. And that's called a secondary pouchitis related to surgery. But for the primary pouchitis, where the thing is pretty good, and the fact that this patient developed the pouchitis symptoms a year or immediately after surgery in the setting of no complications, is the following list. So the workup includes on these patients, you guys know this more than I do, C. difficile stool sample, celiac serologies, flexible pouchoscopy, MRI of the pelvis, of that slide, not barium, gastrograph and pouchogram. You treat these things, you stop the nonsteroidals, treat the infection, but it can go all the way to the biologics, and if the things don't work, it may even go to the surgery itself. I think this is a good algorithm. If somebody comes back with the pouchitis, you go ahead and start with the medication therapy. If it's an antibiotic responsive pouchitis, you repeat it again if it comes back. If it's dependent, keep them on some antibiotic. Probiotic can be questionable, but as long as they have a proper coverage, I have no objection. If it's the antibiotic refractory pouchitis, why it is? Is it related to some bacteria or the virus? Or is it truly this idiopathic pouchitis related to PSC, IgG4, or the autoimmune? And these are the ones, the medications that you may give and escalate to a higher level even in these settings. But the problem is all those symptoms of these patients can also happen in these settings too. All these things are related to surgical complications or the Crohn's disease. So how do you make sure that it is not one of them? Because we need to realize the fact that even in the best setting, some of these patients will develop an Crohn's disease in the setting where they were absolutely treated as ulcerative colitis for years. This is a reality. So, and most of these patients will not have a histologic diagnosis of Crohn's disease. They actually will be a clinical diagnosis, and that's the reason it's very important to differentiate the two as much as possible. When these things do develop, the risk of the pouch failure is really pretty high. And this one is pretty much the same. So how do you define somebody as a Crohn's disease rather than a surgical problem? Timing again, the history is everything. When somebody did the surgery really well and everything is going well, no problems after the surgery a year or two, and the patients develop complications a year or two after when they had an absolute great time, that's most of the times a Crohn's disease. But if they had a surgical complication followed by the immediate signs of pouchitis, that's usually a mechanical problem. Why this is important? Because this is the thing that I try to teach and preach to my residents and fellows. Number one, when these patients have a pouch procedure and everything went well, and then the things did not work out, but they say the fact that, doc, I'm happy with an ileostomy, leave me alone. Trying to convince them the other one for a redo pouch surgery is the biggest disservice. The other thing is, one sometimes cannot live happily with a permanent ileostomy because you don't have the infrastructure, merit, or the skill set. Trying to convince them go back and live with an ileostomy is also the biggest disservice. So reoperative pelvic pouch surgery starts with humility, teamwork, respecting the patient's rights, patient's opinion, pathology, unpredictability, what I talked about, operating room, consistent staff, and strategize, and repetition is very important. So this is a case presentation. It's a patient of mine, 53 years old, 20 years of ulcerative colitis, dysplasia, surgery 2003, one-stage IPA, and no ileostomy and mucosectomy. Was done by a surgeon who does these 4 or 5 a year. I'm not trying to be disrespectful, but this is pretty much get a gun and shoot each other and get it over, and it's the same. So it's not right. So there is a practice that's going on, unfortunately, in our country, in the world, that we need to realize, and this type of procedure really needs to be centralized. It needs to be done in the infrastructure and the head and the teams that can handle not doing the surgery the right way, but also the complications. I made this point again and again. My father was a surgeon, and one of the points that he used to always say, don't be critical of your colleague's complication because the thing is going to happen the next day to you. So I'm speaking that with that humility, but I'm also speaking with the assertiveness, the fact that I haven't touched a gallbladder or pancreas the last 30 years, and you don't want me touching your gallbladder or pancreas ever again. So the repetition and the subspecialization is incredibly important in the IBD surgery. So post-operative immense, this patient had all these sagas. Guess what? You guys know this very well. Suddenly, the surgeon says the fact that, oh, the fistula is healed. Excuse me, everything is healed. Now the patient developed a fistula. This should be a Crohn's disease. Purely a complication related to a surgery, anastomotic leak that the patient never healed. And the patient got treated years and years with the biologic therapy with no result. So this patient went to a redo procedure, and actually she's playing an elephant polo right now. So everybody has a different lifestyle, you know what I mean? I love to play elephant polo one day. But it can be done. It can be done. A redo pouch surgery can give the quality of life back. As what I said, when you get these patients, number one thing, check your own steps and others' footsteps. Did the patient have a perioperative septic complication? When did the issues of the pouch dysfunction start? 6 months to a year, check the footsteps. It's usually the surgeon. Beyond that, it's likely the Crohn's. We have done this before. In the past, when I was in Cleveland, we did the studies, the fact that close to 80% of the patients that were referred to as a Crohn's disease for a potential consideration went through a redo pouch that they did not have a Crohn's disease. I have the privilege of joining NYU the last 3 years, and we still get significant amount of patients all over the country. We had 77 patients including the study. 70% of these redo pouch persons were treated as a Crohn's disease, where 43 now had redo, and 9 are being to go to another redo. And the results in the short term is pretty good. So what is the message? The thing that you are put on your lab as a Crohn's disease can be a mechanical defects that mimic a Crohn's disease, a chronic pouchitis. So when these patients come to you, again, history, what happened after the surgery is very critical. So why I'm putting this there, all these things, again, the point that I'm trying to make. If you're gonna do this redo pouch surgery, you really need to have the infrastructure and a thought process to be able to handle that thing collectively as a team. Number one thing, when these patients come, they're very sick, they're really deconditioned. So in these circumstances, I like to give them an initial ileostomy to recondition them. But anything like in the reoperative surgery in the abdomen, I tell to my residents and the fellows is you have to think 2 or 3 steps ahead. So why? When you give this ileostomy, I call this a thoughtful ileostomy, you need to give this 20 centimeter above the old pouch. Why? Because 60% of the time you can use the old pouch, 40% you cannot. But if you do the ileostomy here or here, you cannot do this, bring this ileostomy as a new J pouch, hook it up. Then you have to go all the way up there. So that's going to bring an issue with a short bowel syndrome to the patient. So art of the colorectal surgery to see the things couple steps ahead. So when we do these patients, what the matter is for us, most of the time they have chronic inflammation and the chronic pouchitis feeling that you're treating as an idiopathic pouchitis. Not. It's the chronic leak. And this leak needs to be excised, cleaned up, and after a mucosectomy, and the pouch needs to be reattached again, which gives a good amount of the success rates. Again, this patient was a 9-year girl from Kansas when it was referred to us many years ago. And I begged the mother, you gotta let me, and this is, by the way, the concept of the MIS, we're talking about how it's being used, too much to push as a marketing. At the end of the day, what matters for these patients to live long life well, not the size of the incision. So I'm not blaming the MIS, I'm blaming the mindset, trying to do shortcut and compromise what needs to be done. So this patient had 2 laparoscopic exploration, all good, all good. It's all in your mind. You may have a Crohn's disease, or it may be a pelvic floor issue. Go and live the permanent ileostomy. It's a humbling situation, can be seen here. What is the problem here? Pouch twisted 360 degrees when it was being anastomosed. So every time they closed this child's ileostomy, the patient was getting a bowel obstruction. So humility must be part of our life in the operating room every time. This is a patient that was referred with a major, colectomy for ulcerative colitis. But surgically, what was done, this was converted from a ulcerative colitis, converted to ulcerative proctitis. So the patient's symptoms did not improve. He did not have an ileal pouch anal anastomosis. He had an ileal pouch rectal anastomosis and suddenly became again, it's not working, and the length of the cuff is close to 12 centimeters or so. This is another patient who was at a twisted pouch, and we left the meso behind, and the pouch gets strictured, and the patient was not able to work. This is a patient from Vermont. Can be seen here, the cuff and the rectum was left behind. That this is the seminal vesicle and the denonvillia fascia anteriorly there. And then we are able to mobilize the things and come across and restaple it again, which means the fact that they had enough cuff for me to do another staple, ileal pouch anal anastomosis, where the patient was suffering due to ulcerative proctitis for years and being not listened. So this is the way how the things well, and this patient is actually doing great right now. This is also another sad patient of mine who was really not listened. Listening to the patients were critical. It's all in your mind. You may have Crohn's disease, but what the patient had briefly. This patient had not 360, but close to 360 of an unintentionally created twisted anastomosis, how he has been suffering with misery for these years. Look how the things are going to be really twisted back to normality, how the pouch should have been oriented. And you do nothing to this patient with the biologics to treat Crohn's disease for the pouchitis, it's going to work. So transabdominal redo surgery, can it be done? It's done. This is the article before I left that we published it over 250 of these things personally. I'm proud of the fact that it was done myself because it really needs the passion and the commitment. It's really a significant amount of labor intensive. It's about the teamwork. The success rates, these patients are very good, over 10 years, 82% of success rates. Their quality of life for you and for me may not be great. Look at these restrictions. But these patients, 92 to 93%, they say that they would have recommended to others or would undergo again. So we cannot judge people with the standard of living right now. We can only judge them the things and the desire and the aversion to avoid a permanent ileostomy, and we need to respect that and make the things better. So they're better than before. How about in the setting of a Crohn's disease? One thing is we don't know what exactly Crohn's, what is not Crohn's, but if it's a true Crohn's disease, we'll look at our results in patients that who had an initial Crohn's disease unintentionally in the setting of Crohn's disease versus intentionally in the setting of a Crohn's disease where we did a redo pouch. The results are not great. You know, these group of patients, they did good overall when we look at it, but the results are good in the sense of the quality of life and the function, but the survival of the pouch in the setting of a redo Crohn's disease is around 40%. Now, you may tell me we should not be doing it. Well, I will make an argument the fact that for somebody who doesn't have a bag, 10 years of chance, 10 years of 40% not having a permanent bag means a lot. So we need to put the patient's perspective, present the data in a transparent way, knowing the fact that we're going to have their bag as long as possible. So I think this is still a feasible option as long as the patient can understand what they're getting into. Do I do Crohn's, J-pouch in the setting of Crohn's disease? It's all about articulation, transparent discussion. I don't do it in a significant perineal disease with the presence of a significant small bowel obstruction. Absolutely not. If they have very limited of the above, as long as they understand what they're getting into, I am very liberal about these things because I do believe the biologics and the medical therapy can open a new era in these settings, complemented with the stem cell for the future on interested parties. Once again, this should not be driven by the surgeon. This should be driven by the patient. This is our numbers right now, the last 2 years, that, again, the patients are seeking. 92%, 92 redo, 95 index pouch patients we have done overall. What is the most important thing? They're coming all out of town. And you know who's the number one referring, the doctors, these patients? Is you, gastroenterologists, because surgeons, unfortunate to say, they have an ego bigger than a Mount Everest that needs to be brought down. So if somebody is not right, is not doing well, they need to be listened to get a second opinion or so. I think a value, and the gastroenterology colleagues has been incredible, a big resource for these things. I think the results are pretty good right now. I think it's the same inclusion, and it's a great privilege being here again. Thank you so much for your time.